Good morning, everyone. For today's class discussion, we have a clinical approach and management of the pediatric ovarian tumors. In this class, we will look into the presentation and classification of the ovarian tumor, diagnosis of the tumors, staging and management of the ovarian tumor. So ovarian tumor is a rare disorder with an incidence of 2.6 to 3 girls affected in 1 lakh of the population per year. The clinical presentation of the ovarian tumor varies as per the age group. The most of the tumors are benign and around 30% of the tumors are being malignant, which constitute up to 3% of the pediatric malignancy. Predominant pathology includes a germ cell tumor, which comprises 77.4% of the population. Anatomical and physiological processes are dysregulated because of the ovarian tumor. The management approach to the ovarian tumor is a multidisciplinary approach which includes curative, function sparing, minimal invasive, and sensitive to the psycho-emotional impact on the adolescent girls. Coming to the epidemiology, ovarian tumors are associated with a few of the syndromes, which includes Maffucci syndrome, Ollier syndrome, Cheriak-Higashi syndrome, Lief-Remoni syndromes, and some of the other syndromes are associated with the increased incidences of ovarian tumors. Some of the hereditary and ovarian cancers are associated with the mutations of the BRCA1 and BRCA2 mutations, whereas BRCA1 mutation constitutes up to 70% of the familial ovarian cancer, whereas BRCA2 constitutes up to 20% of the familial ovarian cancers. However, genetic testing in the adolescent individual is still a controversial subject. In women, some of the risk factors include the late age of menarche, early menopause, hormonal replacement therapy, obesity, smoking, and nulliparity are some of the risk factors in the women. As we discussed earlier, some of the predisposition syndromes which can be seen in the high-grade tumors includes the Lief-Remoni syndrome, Ollier syndrome, Maffucci syndrome, and some of the mutations which can be seen in the high-grade tumors includes the BRCA1 and BRCA2 mutations and TP53 mutation, which is a Lief-Remoni syndrome. Coming to the age group, usually the patients who present in the prepubertal age group with the ovarian tumors usually have a germ cell pathology, and whereas in the patients presenting in the postpubertal age group will have the epithelial neoplasm. As we can see from the table, patients presenting with the germ cell tumor, the age group is usually from 6 years to 20 years, whereas in the patients presenting with the epithelial tumors, they are usually less than 20 years, that is a postpubertal age group. Coming to the clinical presentation, the clinical presentation of the patients presenting with the ovarian tumors is variable. The most common symptom is abdominal pain. This abdominal pain can be an acute pain or a chronic pain. In the acute pain, it can be due to a torsion or a hemorrhage or a rupture of the tumor. The chronic pain, whereas it's because of the slow increase in the size of the tumor, which leads to the increase in the abdominal girth and will cause abdominal distension, and it can be associated with the chronic pain. They can have associated non-specific symptoms like anorexia, nausea, vomiting, and weight loss. Some of the tumors can present with the secondary symptoms due to the pressure effects and on the local involvement of the surrounding structures. It can lead to analgesic resistant pain, urinary frequency and urgency, and incontinence because of the pressure of the tumor on the urinary bladder. However, sometimes this tumor can present with a precocious puberty or a virilization because of the production of the hormones from the tumors. Over 10% of the ovarian tumor, be it neoplastic or non-neoplastic, will have the endocrine activity, which can lead to precocious puberty or precocious pseudopuberty. Precocious puberty is because these lesions function autonomously, which leads to the suppression in the level of the gonadotropins, however, increase in the level of the hormones. It can be seen in the tumors such as sex or stromal tumors, juvenile granulosa tumors, or certainly Leydig cells tumors, ovarian cyst of simple and follicular or a luteal type as well. However, precocious pseudopuberty is due to the production of the beta HCG by the germ cell tumor, which includes a dysgerminoma, yolk sac tumor, or a choriocarcinoma. There is another entity called virilization, which can present with the hirsutism in the adolescent girls, which is because of the production of the androgens from the tumors like certainly Leydig cell tumor or a yolk sac tumor or steroid cell tumor or a polycystic ovaries as well. However, masculinization can be seen in the patients with the dysgerminoma due to the presence of a syncytial trophoblast giant cells. There is a syndrome called a Grumbach syndrome, which is where there will be hypothyroidism with precocious puberty and bilateral ovarian cystic masses will be seen. However, these patients will respond to the thyroid replacement therapy and the ovarian tumors will shrink. As we can see from this table, some of the tumors which are ovarian tumors which are associated with the increase in the level of the hormones, it can be seen in the simple ovarian cyst or a follicular ovarian cyst or a luteal cyst, where there will be increase in the level of the estrogen. Some of the tumors of the sex cord stromal classification, like juvenile granulosa cell, granulosa tumor, or a certainly Leydig cell tumor, or a luteinized thecomas, can also have increase in the testosterone level, which can lead to the decrease in the gonadotropins. Coming to the paraneoplastic syndrome, as we know, paraneoplastic syndrome are the systemic effects associated with the tumor, which is not because of the direct effect of the local tumor or any metastasis. It is, however, due to the autoimmune or a hormonal nature of the tumor. So this can present in the in the patients with the ovarian tumor. There can be nervous system disorder or a connective tissue disorder, hematological disorder, cutaneous disorder, or a nephrotic syndrome because of the hormones or any other antibodies produced by the ovarian tumors. Neurological presentations are the most common among them, where there can be general non-specific symptoms or focal signs or behavioral changes because of the ovarian tumors. When we come to the examination, they usually will have a palpable abdominal mass with or without any tenderness. They can be mobile or palpable just above the brim, pelvic brim. And however, in the small lesion, we might have to do a bimanual palpation between the lower abdomen and the rectum. However, vaginal examination is reserved for sexually active patients. Ovarian tumors can have different cell types, which can be arising from the different cell types, which includes coelomic epithelium, stromal cells, or a germ cell. As we can see from this table, patients with if the cell type is from the germ cell, they can present with the benign pathology like a mature cystic teratoma, or can have a malignant pathology like dysgerminoma, yolk sac tumor, immature teratoma, embryonic carcinoma, and choriocarcinoma, and juvenile granulosa cell tumors. If the cell type is from the coelomic epithelial cell, they can have a benign pathologies like cystadenoma or a Brenner's tumor, or they can have a malignant pathology like serous tumors, mucinous tumors, endometrial tumors, or a clear cell tumor, or a mixed variant. If the tumor is arising from the stromal cells, they can be having a benign pathology like a fibromas or a sclerosing stromal tumors, or they can have a malignant pathology like sex cord stromal tumors, or a virilizing ovarian tumors like certainly Leydig cell tumor, or a granulosa cell tumors, or a fibrothecomas. If this ovarian tumor is of cell non-specific pathology, they can have ovarian tissue histopathology, where they can be because of the metastasis or any because of the hematological malignancies. This is a WHO classification of the tumor, which will be discussed in detail later. Coming to the cancer genetics, germ cell tumors are associated with the sex chromosomal abnormalities, which is the theory is that the abnormal karyotypes are associated with the abnormal gonads, which predisposes them to the ovarian carcinomas. There can be other chromosomal anomalies, which includes chromosome 1 and 12. Like when there is a chromosomal aberration of the trisomy 12, there can be stromal tumors, or if there is an isochrome 12p, there can be germ cell tumor, or if there is a deletion of the segment 1p or a 6q, there can be non-random endodermal sinus tumors, and the semic amplification is one of the amplification which is under study by the COG group. Coming to the diagnosis of the ovarian tumor, the diagnosis involves tumor markers, which includes AFP, beta HCG, LDH during serum assays, and imaging and histopathology and IHC staining. Coming to the tumor markers, one of the tumor markers most important is the AFP. The half-life of this tumor, as we know, is 5 to 7 days, and it reflects the presence of the fetal tissue from which the normal progenitor cells arise. So these are useful in the diagnosis when they're elevated above the normal range for that age. As we know that the AFP level is raised in the premature and the newborns, which gradually decreases over the time by the age of 8 months, which comes to up to the level of 8 nanograms. So if there is a elevated AFP, but after the tumor resection, if there is a decline in the AFP level, it implies there is a response to the treatment. However, if it doesn't decline, it means incomplete resection of the tumor. If there is a sudden elevation during the follow-up period, it concludes the tumor recurrence. Another tumor marker which is important is the beta HCG. The half-life of this tumor marker is 20 to 30 hours. So there will be a rapid fall in the level of the beta HCG following the tumor resection. These are produced by the placental syncytial trophoblast. They have two units, that is alpha and beta subunits. However, only one of the subunit can be assessed, that is beta subunit, which we measure in the patients. Elevated level in the level GCT is associated with the syncytial trophoblast. So it is elevated in the tumors like seminoma, dysgerminoma, choriocarcinoma, or embryonal carcinoma. A level of more than 100 nanogram per ml, it is very, it doesn't usually happen, but when it happens, it indicates choriocarcinoma. Coming to the serum LDH and CA125 level. LDH is, as we know, it is a non-specific tumor marker and which is widely distributed in most of the human tissues. So it is not very specific in identifying which type of the tumor is likely. However, it indicates a tumor burden, that is a high cell turnover. So it can be used as a prognostic marker in cases of ovarian tumor as germ cell tumor. Along with that, as we know, it can also be used as a prognostic marker for neuroblastoma or any lymphoid tumor. CA125 is a best marker for epithelial ovarian cancer, and the level of more than 35 units per ml is indicative of a malignant or a borderline ovarian tumor. However, they can also be raised in some of the benign conditions as well. This is a table which is showing the tumor markers in the ovarian tumor. As we know, alpha fetoprotein, it is increased in germ cell tumor like yolk sac tumor, immature teratoma, embryonal carcinoma, and sometimes rarely in Sertoli cell tumor as well. Some of the non-ovarian malignancies where AFP is elevated, as we know, is a hepatoblastoma or a hepatocellular carcinoma. And coming to the beta HCG, it is raised in patients with choriocarcinoma or embryonal carcinoma. However, it can be normally raised in the patients with Down syndrome. Lactate dehydrogenase, as we know, is a non-specific marker which indicates the tumor burden. It is usually elevated in the patients with the dysgerminoma. However, other malignancies where it will be elevated is hematological malignancies, abdominal malignancies, and neuroblastoma or bone tumors. CA125 is another marker of epithelial tumors. However, it is also to be noted that it is raised in breast cancer as well as endometrial malignancies. Inhibin A is a marker which is usually elevated in the granulosa cell tumor. Coming to the frozen section for the intraoperative diagnosis, the role of frozen section is still a controversial thing. Usually malignant it's in the stages of the development of the ovarian malignancy. It is usually it can be benign, borderline, or a malignant lesion, and sometimes all three can coexist in the same tumor. So the diagnostic accuracy will increase, especially for the high malignant and the benign tumors if we use a frozen section. However, it will be low for the borderline tumor. Hence, surgeons are still using the standard approach for the staging in patients with the borderline tumor. Coming to the immunohistochemistry, there are no specific antibody that is given for the ovarian tumors. However, they are useful for the tumors with follicles or other patterns that bring a sex stromal tumor as a differential. Alpha inhibin is one IHC which is produced by the granulosa cells, and it is a specific marker for the granulosa tumor. However, calretin, it is a sensitive marker and it is usually used in the ovarian sex stromal tumors. Coming to the imaging, imaging plays a very important role in the clinical evaluation of the patients with ovarian tumor, and ultrasound being the initial evaluation will give us important information regarding the characteristic as well as the ovarian volume. The normal characteristic of the ovaries in the patients less than 8 years is a solid ovoid structure with homogeneous ecotexture will be there in the normal ovaries. And during and after the puberty, there will be cystic changes because of the follicular activity, and they will be parallel with the ovulatory follicular activity. Coming to the ovarian volume, in the patients less than 2 years of age, the normal ovarian volume is 0.7 centimeter cube. In the post-pubertal age group, the volume will increase and it will become 1.8 to 5.7 centimeter cube. This is a normal range. These are some of the images showing the different ovarian pathologies. In this first, we can see there is a simple ovarian cyst, which is an anechoic thin-walled mass with the thyroid transmission. And in the second one, we can see a torsion where we can see there will be cystic changes in the ovaries. Along with that, there will be fluid debris, and sometimes we can even appreciate the septations. This is a benign tumor where we can see there will be a complex mass that are hypoechoic with peripheral echogenic nodules, and that may exhibit some acoustic shadowing as well. This is an image showing the malignant tumor. Usually the malignant tumors in the ultrasound will have a complex soft tissue mass with ill-defined and irregular border, and there can be central necrosis with thick septations or a papillary projections in the center. There can be vessels in the central or septal or a papillary projections together with a diffuse vascular arrangement, which can be shown appreciated in the Doppler. There can be presence of the solid component, and sometimes even the free intraperitoneal fluid can be appreciated in the patients with a malignant tumor. Coming to the CT and MRI, some of the features of the benign tumors in the imaging includes a size of less than 10 centimeter. Usually there will be a single lesion and which are unilateral. Usually the consistency will be cystic and homogeneous, and they can be well circumscribed. And usually the calcifications are not present in the benign. These are usually the features of the malignant tumors. And ascites, as we discussed earlier, is usually present in the malignant and it is not seen in the benign tumors. Whereas the malignant lesions, usually the size can be more than 10 centimeter, and there can be multiple lesions, and sometimes they can even be bilateral lesion. And the consistency is usually heterogeneous or a solid component will be there. And the shape will be, they will be invasive invading into the surrounding structure, and they're usually present, and the malignant lesions will be having metastatic component as well. And they usually have the calcification within the tumor. Coming to the CT and MRI, it tells us. Sorry. That will have calcification also. Yes, sir. Yes. Coming to the CT and MRI, these imaging modalities will give us the information regarding the origin of the pelvic mass, which sometimes is not established in the ultrasound, and they also give us the information regarding the extent of the lesion, and accurate staging is possible with this imaging modalities. In CT, the benign tumors are usually fluid-filled mass with fat and calcification, and benign malignant lesions will usually have a large solid with occasional cystic areas and fine or a coarse calcification. Dynamic scannings are useful for a torsion and diagnosis of the torsion. And in the torsion, there will be lack of enhancement of the mural nodules and there will be engorged blood vessels. In the MRI, it gives us the information about the soft tissue contrast resolution, and accuracy of the MRI is 91%. And however, in the MRI, the torsion ovary usually will be identified as a high intensity at the rim of in the periphery of the mass on the T1 image. The role of the PET scanning in the ovarian tumor, it may help in the differentiating the.
It is very important to know that there is no investigation that can conclusively tell that the torsion is there. We have repeatedly seen in our department also these cases where they definitely said that there is no torsion, we find torsion. Recently only we operated the completely necrotic ovary, and they said that there is no normal vascularity and no torsion. So this happens. So never rely on the imaging only whether the torsion is there.
It may help in differentiate the role of the PET scan in the ovarian tumor. It may help us in the differentiating the malignant tumor from the borderline tumor. However, it can also be used as an imaging modality for recurrent ovarian tumor with raising serum markers with negative CT or MRI. If there is an incidentally detected ovarian mass, usually we have to, in any of the ultrasound in imaging or done for the other symptoms, we have to get a preoperative AFP, beta HCG, and CA125 level. And if they're normal, we should consider ovarian sparing surgery. And if they're elevated, CT chest or any other CT chest has to be done to look for any metastasis. And hormonal evaluation, if there is any signs of precocious puberty, has to be done in these patients. And the rest of the present management will be carried on. If any incidentally detected ovarian mass,
will operate all the patients of incidentally detected ovarian mass. Will you operate all of them?
Yes, it depends on the type of the lesion. If it is a normal polycystic kidney, or if there is any normal, if the ovarian tumor is, if the ovarian enlargement is there because of the follicular activity, we do not operate.
Mass, very clear, it's not a polycystic kidney. It's not. We are talking about insulated
teratoma is a
non-cystic adolescent and post-pubertal ovarian tumor.
whole thing which is pre-pubertal and
Why I'm asking this is because there is still a lot of confusion about what to do when it comes to it. So let's say we cannot just say that we have all of them. Let's see. मैनेजमेंट में probably we will discuss कि cystic है या solid है उसका depend करेगा you know so cystic में management then pre-pubertal post-pubertal all those things audit तो करवाए होगा audit करा है slides भेजे थे बाहर edit करने के सवाल पूछेगा मैं कुछ सवाल नहीं पूछूंगा मैंने मॉडरेट किया है शट पूछना बनता है मॉडरेशन के बाद भी आप 100% प्रूफ तो नहीं कर सकते और स्लाइड्स का पूछ सकते हैं
coming
ठीक है
the second part is on classification, staging, specific tumors, and management of the ovarian tumors. So the proper management depends on accurate staging of the initial extent of the disease, and the staging depends on the clinical examination, the findings on surgical exploration, the tissue histology, and the fluid cytology. There are various multi-institutional corroborative studies working in this regard, including CCG, POG, and COG mainly. And the standard systems of classification put in place are WHO, FIGO, and COG system of classification. So WHO classifies based on the histology of these ovarian lesions, both as non-neoplastic and neoplastic ovarian lesions. And in non-neoplastic ovarian lesions, there can be follicular cyst, corpus luteal cyst, and other specified ovarian cysts like simple cyst and non-inflammatory disorders. And in other conditions which they have defined in adults include ectopic pregnancy, the benign neoplasms, the ovarian dysfunction like polycystic ovarian syndrome, pelvic inflammatory disease, and endometriosis has also been classified in WHO in this regard.
benign neoplasm to non-neoplastic होता है
Classification में तो so and when it comes to the classification of tumors of the ovary, we can start with the surface epithelial cell tumors as in WHO. There can be serous, mucinous, endometrioid, clear cell tumors, transitional cell tumors, squamous cell tumors, mixed epithelial tumors, and undifferentiated or unclassified tumors. And then we have sex-cord stromal tumors, which are basically derived from the mesenchymal stem cells. There can be granulosa stromal cell tumors, which includes Sarcoma fibroma group and granulosa cell group. And then we have Sertoli stromal cell tumors, sex-cord stromal tumors of mixed or unclassified cell types, which include sex-cord tumor with annular tubules and dendroblastoma. And then we have spheroid cell tumors. And then there are germ cell tumors, which has been classified. Either it can be a primary germ cell tumor, biphasic or triphasic teratomas, and monodermal teratomas. In primary germ cell tumors, we have dysgerminoma, yolk sac tumors, or endodermal sinus tumor, embryonal carcinoma, polyembryoma, a variant of it, non-gestational choriocarcinoma, mixed germ cell tumors, and immature and mature teratomas are further classifications of the biphasic and triphasic teratomas. The other tumors that has been classified in WHO include the germ cell sex-cord stromal tumors, which include gonadoblastoma and the mixed variant. And then there are tumors of rete ovary, the miscellaneous tumors, which include the small cell carcinoma of hypercalcemic type, gestational choriocarcinoma, soft tissue tumors, which are not specific to ovary, other tumor-like conditions, the lymphoid and the hematopoietic tumors, and the secondary tumors. The staging of the tumors was especially for the epithelial tumors, we follow the FIGO classification, which is Federation of Gynecology and Obstetrics, where stage 0 is unspecified, where there are primary tumor cannot be assessed or there is no evidence of primary tumor. Stage 1 is when the tumor is confined to ovary. 1A is tumor is limited to one ovary. The capsule is intact and there is no tumor on the ovarian surface. 1B is when the tumor is limited to both the ovaries, but there is again the capsule is intact and there is no malignant ascites or peritoneal washings. 1C is when the tumor is limited to one or both ovary, with either the capsule is ruptured, the tumor is on the ovarian surface, and the malignant cells can be detected in ascites or the peritoneal portions. Stage 2 is, these are the tumors which involves one or both the ovaries with pelvic extension. 2A is when the extension to or the implants on the uterus or the tubes or both. However, there is no malignant cells on the peritoneal washings or the ascites again. 2B is when the extension to the other pelvic organs are there, apart from the uterus and the fallopian tube. Again, there are no malignant cytology. And 2C is when there are either of 2A or 2B along with the positive malignant cytology is there. Then stage 3 is when there is confirmed spread to the peritoneum outside the pelvis, or there is metastasis to the retroperitoneal lymph nodes. Again, it can be classified into 3A, 3B, and 3C. 3A is where the microscopic peritoneal metastasis is there, or the metastasis to the retroperitoneal lymph nodes. And based on that size, we have 2A1 further classified into less than 10 mm in the greatest dimension of the retroperitoneal nodes, or more than 10 mm. And then there are 3A2 where there is microscopic extrapelvic extension. Then there is 3B where there is macroscopic peritoneal metastasis beyond the pelvis. However, the greatest dimension is less than 2 centimeters of that nodule without metastasis to the retroperitoneal nodes. Then there is 3C where there is macroscopic peritoneal metastasis beyond the pelvis, and that is greater than 2 centimeters in their greatest dimension. Again, retroperitoneal lymph nodes may or may not be involved. Then stage 4 is one where there is distant metastasis. 4A is particularly with regarding to the pleural effusion with positive cytology. And 4B is either there is parenchymal metastasis to the extra-abdominal organs, including the lymph nodes and the lymph nodes outside the abdominal cavity. Then most for the GCTs and other tumors, the COG has also given the classification which we as well follow. Stage 1 is limited to ovary. The peritoneal washings are negative for malignant cells. There is no clinical, radiologic, or histologic evidence of disease beyond the ovaries. However, the gliomatosis peritonei is an exception. The tumor markers negative after appropriate half-life decline is there. Stage 2 is when there is microscopic residual disease or positive lymph nodes, but they are less than 2 centimeters in their greatest dimension. The peritoneal washings are again negative, and the tumor markers may be positive or negative. Stage 3 is when there is gross residual disease is left, or we have done only biopsy on the initial procedure. The tumor positive lymph nodes more than 2 centimeters in diameter is there, and there can be contiguous visual involvement which includes omentum, intestine, and the bladder. The peritoneal washings are positive for malignant cells, and stage 4 is when there is distant metastasis, including liver. Coming to the individual tumors and the treatment of the ovarian tumors per se, we know that the germ cell tumors is based on the theory by Thalium, who proposes the origin of germ cells based from the pluripotent germ cells. The gonad is the most common site for GCTs in children. The ovary occupies 30% of these GCTs, and the specific type of GCT depends upon the degree of differentiation, which can be given by, which was the theory proposed by Thalium. Either if it is originating from the primary germ cells, it can result in germinomas, including dysgerminomas. And on further differentiation, we have embryonal carcinoma, which if there is extraembryonic differentiation, there can be yolk sac tumors or choriocarcinoma. Or if there is further differentiation of embryonal carcinoma per se, on somatic differentiation is there, we can result in teratomas. So the surgical guidelines of ovarian GCTs has been given by COG, and as well as the same has been compiled by ICMR as well. The goal of surgery includes complete evaluation of the extent of the disease, the safe and complete resection of the tumor per se, and sparing of uninvolved reproductive organs as much as possible. However, the guideline says that if there is suspected ovarian malignancy detected at the time of laparoscopy, if MIS is preferred, complete surgical staging and resection has to be done by conventional laparotomy, which is recommended. And the guideline includes the upfront resection if it can be done completely without any undue morbidity or the risk of rupture or the residual disease. Otherwise, they advocate 2 courses of neoadjuvant PEV regime followed by the response assessment and surgery. The remaining courses, either 1 or 2 cycles which has to be given, will depend upon the stage of the tumor. And some of the specific steps that has been emphasized by both COG and ICMR for surgical management of ovarian GCTs include any trocar, drainage, or aspiration of the fluid at the beginning of the procedure to decrease the size to facilitate the resection will be regarded as tumor spill, and that results in upstaging of the tumor, minimum of stage 2. On laparotomy, the peritoneal fluid or the peritoneal washing, if at all there is no fluid, either by Ringer lactate solution or normal saline, has to be done for cytological examination. If not, that will upgrade the stage to stage 3. And enlarged paraaortic lymph nodes should be biopsied. However, retroperitoneal lymph node dissection is not mandated. Any peritoneal or omental deposits, if at all they are present, has to be biopsied. The omentectomy is not generally preferred. Only the portions which are adherent to the tumor per se is resected. The contralateral ovarian biopsy is done only if there are any suspected nodules on its surface. Otherwise, it is not preferred. When we encounter bilateral ovarian tumors in such a case, we can prefer wedge biopsy of one, followed by neoadjuvant therapy, and then go for a second look surgery. However, if it is associated with DSTs like XY-DST, bilateral oophorectomy is recommended. Individual tumors. So, over a period of time, there were various chemotherapies that were tried for ovarian GCTs, starting from VAC, and then cisplatin-based therapy was started for testicular germ cell tumors in adults by Ihon et al., and which was adopted in ovarian tumors with increasing success subsequently. Other regimes like VAC, platinum-based regimes, and carboplatin instead of cisplatin, all of them have been used. And current regime with proven efficacy and reduced morbidity, and which is used by COG commonly, is the PEB regime. And the chemotherapy depends upon the risk category in the COG regime. Initially, the ovarian tumors were classified into stage 1 as low risk, 2 to 4 as intermediate risk, and there were none stage 4 in high risk. But because in one of the trial they found that there was low risk strata, they had to stop because more and more patients had decreased the 3-year event-free survival. So then they classified even the stage 1 as intermediate risk, and along with stage 2 and stage 3, and stage 4 has been the high risk, contrary to the testicular tumors. And the BEP regime that has been advocated also differs from adult and the pediatric population, where the dose of the bleomycin is different, and also the scheduling of the bleomycin is as well different, where in adults we give weekly regimes, where in pediatric we give only on one particular day. And there is another regime that is JUB, which uses carboplatin instead of cisplatin. Role of carboplatin instead of cisplatin. Recently, there was a systematic review by Sheikh et al. Proposed that carboplatin should be used in younger children with low or intermediate risk features, that cisplatin should be reserved for older children with high risk features. The UK group of the germ cell tumor study consortium, they also advocate carboplatin instead of cisplatin. They have been using it since 1989 with good outcomes, and but still they recommend to use the standard PEB regime instead of JAB in adolescents, that is in older children. According to the ICMR guidelines, the carboplatin can be used if there is any pre-existing renal damage with or without JAB regime, along with the reduction of dosage of bleomycin. Role of biopsy. Usually the clinical and the radiological evidence of a heterogeneous tumor in one of the expected location of the GCT, along with the elevated biochemical markers, is sufficient to diagnose the presence of GCTs, and biopsy is rarely indicated. However, there was one particular sentence that FNAC or core needle biopsy required only if the AFP is not elevated and neoadjuvant chemotherapy is contemplated. Retroperitoneal lymph node dissection is again not a part of standard pediatric germ cell tumors, unlike in the adult germ cell tumors where it is mandated. Radiotherapy again is not routinely advocated in the management of these tumors. It is, however, the standard of care in CNS germinomas, but other subtypes usually they are not responsive or they are associated with increased morbidity. The recurrent germ cell tumors, especially those which are unresectable following the salvage chemotherapy, may be treated with radiotherapy. And there are new target therapies as well, which has been described, especially in adults for both GCTs and non-GCTs, which act on particular levels like kinase inhibition or CDK9 inhibition also. The drugs include imatinib, abociclib, bevacizumab, and ketoconazole. All these drugs are still under trial, and none of them have been added with proven efficacy in children. Coming to teratomas, they comprise elements foreign to the organ of anatomical site. Usually they should have 3 germ layers, but it's not essential. There can be mature, immature, or the one with monodermal components. And the benign cystic teratomas are most common ovarian neoplasms in children, which can be bilateral in 10% of the cases, and they are arrested in meiosis 1. They can be acute or chronic presentations, like we already saw, and investigations are usually X-ray, where we can see calcification, ultrasound, and MRI. So usually for management of mature cystic teratoma, in the same line of COG that we just discussed, usually conservative ovarian surgery is recommended. The traditional is when we encounter the cystic component inside, the conservative surgery is recommended. With traditionally oophorectomy by laparotomy was performed, and currently laparoscopic removal is the method of choice, and it has been followed in most of the case series that we could see. And the cystectomy and enucleation is preferred over oophorectomy even in these cases. So all the advantages of MIS adds to the procedure. At limitation is the longer operative period, and one thing that many of these studies and even the systematic reviews emphasized was high content spillage rates in laparoscopy. And usually the dimension for conversion to laparotomy is more than 10 centimeter. So this was the systematic review. So there were certain methods which are proposed to prevent spillage. One is like we commonly use the endo bag. The Campo et al. Proposed an RCT where the endo bag reduced the spillage from 46% to 3.7% in either of the groups. And dissection can be performed either within the endo bag once after placing the endo bag, the tumor into the endo bag, or it can be performed outside the endo bag, but that risks some of the content spillage into the peritoneal cavity. And the another thing that was proposed was to start dissection from the mesial side by incising the ovary on the mesial side for cystectomy. Mesial side is the anterior hilar margin of the ovary, where the tubal fimbrius is closely applied to the ovary. So this is one such thing. And they also found there is a reduction in the spillage. This was again an RCT where they found a reduction in spillage on the either sides. And then another thing that we encounter in these tumors is the torsion. So there is no role of any expectant management here. Emergency surgery is indicated, and most torsions are of benign pathology itself. And ovarian mature cystic teratoma is prone because it is having long pedicles and they're large usually. The presence of flow in the color Doppler imaging does not allow the exclusion of the diagnosis, which can still be present. Emergency laparoscopy can be used for untwisting the ischemic adnexal mass, which is recommended in pediatric population. Even the persistent black color of the adnexa after untwisting is not an indication for systematic oophorectomy. Functional recovery is still possible. The fixation is usually not recommended, and if the ovary is completely necrotic and it has formed an abscess, then it shall be removed. And during the surgery for torsion or incidental surgery during the laparoscopy, if we find the ovarian malignancy with an ovarian tumor with an extra ovarian spread, external ovarian vegetations, the size more than 8 centimeter, or the evidence of numerous vessels, with giving us the suspicion of malignancy in these patients, even then we go for a second procedure after evaluating the tumor markers by biochemistry, and not immediate oophorectomy or any procedure should be performed.
So this is the answer to the question. When a patient comes to emergency with pain and trauma, there is a suspicion of torsion and a mass is there. Now you cannot do a tumor markers immediately, even if you send the sample, if the report will not come. You are not sure whether the tumor is benign, malignant, and what exactly to do, whether you can get away with the cystectomy or does the patient require oophorectomy. You will go in these patients, detort it, leave it like this, send the wait for the report of the biomarkers. If the biomarkers come positive, do the oophorectomy as per the indication. And if the biomarkers are negative and no feature suggestive of malignancy, then you can do either a cystectomy, or if it is a follicular cyst only, then the procedure is done by untwisting only. This is what you are supposed to do during the emergency presentation of these patients.
Then there is an entity called gliomatous peritonia in these tumors, where there are multiple intraperitoneal glial implants with mature teratomas, which has been seen with mature teratomas. Usually they are 1 to 3 mm white gray nodules, like we can see usually on omentum peritoneum or the tumor itself. The origin is usually the subperitoneal pluripotent Mullerian stem cells and not the tumor per se. So when we find suspected nodules like this, we can go for an intraoperative biopsy. If it is well differentiated, there is no specific treatment per se required. And if it has any immature component, based on the tumor histology as well, we can go for further adjuvant therapy and management. The immature teratomas are immature because on histology they have neuroepithelial components which can be seen, which can be graded. The most accepted classification has been given by Gonzalez Cruci et al. Based on the percentage of this embryonal and the neuroepithelial components. Grade 1 with less than 10%, grade 2 with 10 to 50%, and grade 3 is more than 50% immature components. Even the gliomatosis peritoniae are more frequent here than the mature component itself. There have been reported metastasis to liver, retroperitoneum, momentum, mediastinum, and brain by hematogenous route. There is an entity called growing teratoma syndrome, usually more commonly associated and seen in adults on chemotherapy. That is, after chemotherapy for germ cell tumors, the lesion continues to grow without the elements of malignancy. The prognosis basically here depends upon the tumor grade, which has been described, followed by the stage, incomplete resection, yolk sac elements, and so. The management is usually fertility preserving surgery and observation without any adjuvant therapy as far as COG and POG guidelines. The risk stratification of ovarian GCT, another risk stratification apart from COG was given by a consortium consisting of both COG and as well as the UK group, which has been regarded as the MAGIC consortium risk. Here they have classified stage 1 as low risk, stage 2 or 3 based on the age of the patient comes in the intermediate or what they call standard risk, and stage 4 with more than 11 years has been regarded as poor risk group in the risk stratification. However, COG says stage 1 to 3 as intermediate and stage 4 as high risk category. Coming to dysgerminomas, usually they are primary malignant tumor in the dysgenetic gonad and most frequent ovarian malignant neoplasm, which can be seen 25 to 30% of the cases, and they are common in prepubertal girls as well. And they are bilateral in 5 to 30% of the reported literature. They are large tumors. They can present with acute or malignant, acute or chronic presentations that we saw now. And paraneoplastic syndromes or hypercalcemia is usually associated. And in pure dysgerminoma, the LDH can be elevated. And the management, again, by following the surgical guidelines emphasized. So we can go for the surgical excision. Here they say surgery alone suffices in stage 1, while CT is recommended in advanced stages. And careful staging has to be done intraoperatively. The chemotherapy which has to be given is the BEP regime. Radiation, although these tumors are extremely radiosensitive, but that has been abandoned with the advent of the BEP regime chemotherapy because pelvic radiotherapy has high risk of morbidity and sterility. These patients are followed up every 3 monthly after the treatment for first 2 years, followed by 6 monthly for next 3 years, and annually for next 5 years. Then we have. We have tumor markers.
You will be able to consent the patient for even that for taking out the gonad.
We have the biochemical markers like LDH is elevated, so we know that it's a malignant, and then they can have both cystic and as well as the solid components on the imaging that can be presented.
Again, coming back to the same question, when you decide to operate, what approach you have to use, whether laparoscopy or open, whether you will do a ovarian sparing surgery or in these tumors, and how you will consent the patient. So the pre-operative planning is missing in this, and how you decide. You are saying do this surgery, do this like this, don't do this in the surgery. But actual decision making, we are not coming there. We're going from tumor to tumor, but how we will decide. Suppose I have like a 10-year-old girl with 6 centimeter tumor, complex tumor on CT scan, on cross-section imaging, with mildly elevated LDH. What will we do?
We'll go ahead with this. It's prepubertal age groups, one thing. And then there is a complex pathology. Either way, surgery is
6 centimeter
is
complex lesion or surgery
preferred. So, because it is of complex radiological findings are present, we go ahead with oophorectomy. Initially with oophorectomy, fallopian tube is there, salpingo-oophorectomy, and then we'll decide on further management later because it seems operable. And
the question I'm asking you, how do you know? This is the borderline. How do you know whether you will do ovarian sparing surgery or? So what are the conditions in which you can do ovarian sparing surgery? The question, simple question.
like in mature in cystic components like mature cystic teratomas, teratomas or the benign.
Is there any imaging characteristics that can definitely say that yes, this is a teratoma? There are certain features which can definitely say that this is teratoma. Suppose the fat is seen, calcification is seen, you are sure that this is teratoma.
Heterogeneous. Yes.
There will be certain cases where you cannot definitely say what it is, or features of teratoma are not there, a complex mass is there. The markers are not raised. Now, this is the situation where you are not sure whether this patient is having a malignant tumor or it is a benign condition. So, depending upon the extent of solid components within the mass, if it is a cystic lesion, you are more biased towards the follicular cysts and the functional cysts which are there. But if it is a solid cystic lesion, a complex lesion, and the patient who is symptomatic, in these patients, if the features, imaging features are not suggestive of teratomas, then you will go towards
Oophorectomy.
वो major factors क्या है when you decide whether to operate vesicular scanning, gradient scanning versus
One is the clinical, including the age group of the patient, prepubertal and postpubertal. Then we have the radiological findings, imaging findings. Then there are biochemical markers,
tumor markers,
tumor, and then size of that more than of the
factors which you take into account while deciding.
10 centimeters for laparoscopy.
Normal
Normal for surgery, consider for surgery 5 centimeters, more than 5 centimeters.
Consider for surgery or to oophorectomy versus sparing?
No, oophorectomy is sparing का नहीं है कोई criteria. There is a criteria for surgery. There is a
5
criteria for laparotomy. More than 5 centimeter for doing surgery. More than 10 centimeter for doing laparotomy. Any evidence of malignancy based on any of these features जो सर ने बताया, again malignancy का feature है, तो आपको laparotomy करनी है, oophorectomy करनी है.
What I remember is in the recent paper, less than 5 centimeter, more than 5 centimeter, you can consider ovarian sparing surgery. And if the biopsy shows, or if you are able to do them, plus the proper biopsy later, if it shows, you go and go again inside and do a complete surgery. That is what is my knowledge about it. What I'm trying to say is that we can discuss this, go on and on with the chemotherapy and all these things. But when it comes to the real clinical situation and the actual patient, what I described is a 10-year-old with this. Deciding the management is not very easy, and unfortunately, we are not able to discuss that in this seminar.
I'll put it.
बताओ 4 major age groups हैं ovarian tumors, right? एक है neonatal, then है childhood, then peripubertal and adolescent, and then there are adults. All of these are absolutely different diseases.
Yes, sir.
You have idea what's the common thing?
In germ cell tumors in neonates, usually they are extragonadal and yolk sac tumor.
Yes, question from the germ cell tumor not good.
Ovarian tumor.
There is a tumor in the ovary in a newborn. We don't know it is.
There can be cystic lesions that can be seen, sir, and also they can have extragonadal lesions more commonly, like yolk sac tumor, cyclopoccygeal teratomas also. And then when it comes to the prepubertal and adults, usually in the children and the prepubertal age group, the GCTs are more common, while in adults,
Yes.
epithelial tumors are more
Yes,
common.
what I am asking is, you have a neonate on the sound, there is some cystic lesion in the 6 centimeters.
That can be followed up, sir. I didn't come across neonatal tumors as such particular.
I come across. You see it. ये लाइफ में भी देखा होगा एक बार at least. Yeah. Accidentally some cystic lesion in that domain. the neonatal and then what is the postnatal summary ultrasound, and then there's ovarian cyst. Yeah. Dynamic situation. Yeah. Don't jump to Johnson, how do you mistake? You should say that I like to go side CT scan. I'll look you one is already elevated in your one. These are critical situations. You should make algorithm. Then only we always understand that what how are you planning. Neonatal to come. 4 ages, but I don't know. Neonatal.
क्या करोगे बताओ आंसर दो न्यूमेरिकल में कौन सी टेक्नोलॉजी होती है कॉमनली एंड हाउ वी फॉलो दैट
Usually, there can be the mature cystic teratoma can have neonatal presentation along with other benign conditions like the cystic lesions, corpus luteum cyst, or other functional cysts.
most of them are benign. How do you follow
They can be followed up and observed with regular ultrasounds, and serial observation is usually for up to, I'm not sure, sir, but I think it is 2 years.
This is all the one now.
So how frequently that was the question. One period
Every 3 monthly ultrasound and biochemical investigation.
We divide them in symptomatic, asymptomatic. If it's they are painful and the child is having discomfort, then you have to consider something. Asymptomatic usually there. Then you follow up. Initially you will do one ultrasound every month or 3 months, then 3 monthly and then 6 monthly till it resolves.
Yes, sir.
This may be size.
Size.
Neonatal is normally
And the
physiological cysts,
Yes.
right? Functional and physiological cysts. Let's say childhood.
Then the
common diagnosis क्या होती है?
teratomas
Mostly teratoma
followed by
Johnson.
Johnson.
उसमें कैसे decide?
Again, in this, we have well-defined criteria based on the, if at all these tumors are there, based on the biochemical, radiological, and the age group and the size of the tumor, we can consider the surgery in this patient. And especially if it is associated with some conditions like associated with DSC, where we may have to delay the surgery till the post-pubertal age group in one of the condition. Otherwise, usually surgery is preferred. In adolescent and the adult age group, usually the epithelial tumors also come into picture where they are seen, and even commonest is again GCT in adolescents as well, followed by the epithelial tumors, and other tumors follow that. And in adults, epithelial tumors are more common than
all 4 age groups are
different. Yes, sir.
must have some care.
Okay. Yes, sir. Then we have the endodermal sinus tumors, which are usually aggressive malignant neoplasms. They either can be present isolated or in mixed GCT, second most common malignant type. And the primary tumor is usually ovary in children and adolescents and sacrococcygeal area in neonates. They can present with acute and chronic presentations, and elevation of AFP is the hallmark. The prognosis is usually unsatisfactory decline in AFP after chemotherapy, the residual tumor after debulking surgery, the ascites, and increased stage at the diagnosis. And BEP regime is a good one, and histologically they are characterized by Schiller dual bodies. So the chemotherapy advocated here is the BEP regime, the first line in all stages early in the course. The 3 cycles in favorable prognostic factors, that is early stage and optimal debulking is there, and 4 cycles if it is unfavorable. The surgery is again the standard laparotomy and salpingo-oophorectomy, and appropriate staging, and this has to be done as per the COG guidelines. The embryonal carcinomas, oophorectomy, if at all fallopian tube is involved, then salpingo-oophorectomy.
The difference between here and the surface epithelial. Those you do
Yes. And we have embryonal carcinomas. Usually, again, they are more commonly associated as mixed GCT associated with other GCTs. The subtype is a polyembryoma, which produces beta-HCG and AFP causing endocrinopathies. The management, isolated unilateral tumors by unilateral oophorectomy, and advanced disease, hysterectomy and multi-agent chemotherapy has been done in these cases because they're highly aggressive. And embryologically, they resemble the bodies that resemble tiny embryos. Choriocarcinoma, again, it is usually seen as mixed germ cell tumors, and they are endocrinologically active, estrogen producing both by the tumor and the ovary because of the GnRH stimulation. And they are known to have local adhesions, infiltrations, and metastatic potential. So if it is localized tumor, unilateral oophorectomy or based on the involvement salpingoophorectomy, and if it is extensive, they have to be treated with extravasative surgeries. Where contralateral ovary, uterus, and metastatic disease based on their respective involvements may have to be removed. Chemotherapy is usually BEP is followed, and there has been other regimes like methotrexate-based regime which has been used here. And surgery alone will have only 28% survival known in literature, and if associated with chemotherapy, they are known to have 82% survival. The mixed germ cell tumors, the 2 or more malignant germ cell components are present. The most common combination is dysgerminoma and endodermal sinus tumor. And least common combination is embryonal carcinoma and immature teratoma. So they are usually peak incidence as in adolescents, and the standard treatment protocol is the adnexectomy along with the other surgical principles based on their involvement has to be followed. Then there is a particular situation when there is the recurrence of this germ cell tumors. The management is basically based on the primary histology. We can start with the salvage chemotherapy regime where multiple regimes has been proposed, including the high dose cisplatin PEB regime, or the VIP including vinblastine, and the ICE regime, which is also used. And also there are multiple stem cell rescues which has been tried here. If the surgical resection is feasible after the end of salvage therapy, we can go for surgery. If it is unresectable, then we have to consider radiotherapy in one such rare case. The surface epithelial stromal tumors are less common in children and usually becomes more common in adolescents and adults, and 15% of surgically resected tumors are them. There can be serous or mucinous, where in serous there is usually 20% bilateral, but malignancy is less, and mucinous, they have 10% risk of malignancy. And these are staged as per the FIGO system that we saw. And the management here in stage 1A is usually unilateral salpingo-oophorectomy. We have to examine the contralateral ovary biopsy from the surface abnormalities. Stage 1B is bilateral gonadectomy. Uterus is preserved. In advanced stages, which are not common in children and seen in adults, we have to go for maximum cytoreduction, including the hysterectomy, salpingo-oophorectomy, omentectomy, and other things. And chemotherapy is cisplatin, cyclophosphamide, and paclitaxel is preferred in adults. And there are novel biological therapies like I enlisted as well. The tumor stage is most important prognostic factor in these particular tumors. And there is another entity called borderline ovarian tumor, BOT, which is tumor of low malignant potential. They are histologically and biologically intermediate between the benign and the malignant epithelial lesions, usually seen in younger children. They have better prognosis. They can occur in any subtypes, both mucinous or serous. And there are no stromal invasions like we can see in malignancy on histology, which differentiates it. 50% they have bilateral disease, and they have usually indolent clinical course. The surgery, the primary and most effective method of therapy is here surgery. Salpingo-oophorectomy and ovarian cystectomy both has been performed. If ovarian cystectomy is performed, it has been strictly followed up with pelvic examination, ultrasound, and CA-125 assays. And in bilateral cases, bilateral salpingo-oophorectomy versus oophorecystectomy is the debate that is ongoing. The role of adjuvant therapy as such is not identified in these conditions. And for epithelial tumors, for surgery, like we saw COG in germ cell tumors, here we have FIGO guidelines, which recommends peritoneal biopsies, peritoneal washings or aspiration. Omentectomy is advocated here. The removal of the primary tumor per se, the ipsilateral lymph node dissection. Here, lymph node dissection is just not based on the gross appearance, because 30% of normal looking lymph nodes here can also have the malignant or metastatic component in them. So that is recommended. The other small tumors are sex cord stromal tumors, where they also arise from the mesenchymal stem cells, and they're usually functioning ovarian cysts, which will have systemic hormonal effects. And so up to 17% of malignant potential has been described here. Usually in these patients less than 9 years of age, they are usually feminizing neoplasms, and more than 9 years, they become virilizing neoplasms. We have one such thing is granulosa theca cell tumor, which is most common among these things and most common functioning ovarian neoplasm as well. The juvenile variant is most common, 44% in the first decade of life, and they are usually associated with isosexual pseudo-precocious puberty, and they are usually unilateral. The biochemical and histological findings are common. And the management, the juvenile tumor is usually aggressive, and depending on the tumor size, the disease stage, the presence of rupture, and the degree of atopia which is present, it differs. usually in children, these tumors are found to have favorable prognosis because more than 90% of them are detected as stage 1, and stage 1 unilateral salpingo-oophorectomy is advocated. However, in the advanced stages, if we have to go for surgical resection along with the platinum-based chemotherapy, radiation is reserved for recurrent and non-responsive granulosa cell tumors. Then we have fibromas and thecomas in this age group, which accounts for 14% of these tumors, and they are associated with basal cell nevus syndrome. They're usually bilateral, multicystic, and calcified. They can have the systemic endocrinopathies, including hirsutism, amenorrhea, and androgenic manifestations, for which they usually come to us. And management is unilateral oophorectomy. If bilateral, we have to resect the gross tumor tissue, sparing the normal ovarian tissues. Then there is sclerosing stromal tumors, where 30% of these are seen in first 2 decades of life in pediatric population. Estrogen secretion is reported. They are associated with Chediak-Higashi syndrome, and again the management is gross tumor resection per se, because even these are unilateral, but they are large in size. Another entity is Sertoli stromal cell tumor, which is characterized by initial clinical presentation of initial defeminization followed by subsequent masculinization. Usually they account for 10% of these tumors. They were previously called arenoblastoma or androblastomas, but now they are regarded as Sertoli stromal cell tumors. And because there have been in reports of estrogen secretion in these tumors as well. Mostly they are unilateral and stage 1A, and management is oophorectomy or adnexectomy. And if it is bilateral or extensive, it warrants aggressive resection. And advanced stages demands chemotherapy of BEP regime. The other regimes tried are CAP and PAP. And here the OCPs and GnRH agonists are usually given during the chemotherapy as an ovarian protective drugs.
This slide seems to be my first slide.
They're just a brief note. Then we have sex cord tumors with annular tubules, which are usually rare, and they're associated with Peutz-Jeghers syndrome. And they also can be cured by unilateral salpingo-oophorectomy. The complex annular tubules in this are the histological characteristic feature. Sertolid cell tumors, again, they are rare. Previously, they were called lipid cell tumors, and now the Sertolid cell tumors. The management is again unilateral salpingo-oophorectomy, and follow-up has to be done. And the another variant which is present is gonadoblastoma, which occurs in patients again with dysgenetic gonads. They are composed of germ cells and sex cord derivatives, may or may not have lutein or Leydig cell components. They are androgen producing, causing virilization, and usually they present with virilization and primary amenorrhea. And 90% of this patient will have abnormal karyotype with Y chromosome 46XY dysgenesis is associated. There is an entity called burnt out or involuted gonadoblastoma, where they undergo complete involutional changes, and only calcification is what it remains of the tumor per se. And more than 50% are associated with other GCTs, that is dysgerminoma. The management, they have a tendency to become invasive or malignant early, so gonadectomy with hormonal supplementation with or without that is recommended. And in adjuvant therapy, if associated with malignant GCTs, has to be done based on the malignant potential. And there are some miscellaneous tumors which has also been reported. Most of these are rare, but they are extremely aggressive and associated with poor prognosis. Some of them are small cell carcinoma of ovary, primary ovarian sarcoma, the stromal sarcoma, low-grade endometrial stromal sarcoma, the ovarian fibrosarcoma, and leiomyosarcoma. Usually they are not commonly encountered and rare. And some of this, like small cell carcinoma, can be treated with bilateral or unilateral salpingo-oophorectomy based on their involvement and chemoradiation. Again, we have poor life expectancy of only 18 months, while most of others demand extensive surgical therapy like hysterectomy and adnexectomy. The secondary tumors, again, the ovary has a potential but rare metastatic site for childhood malignancies, which can occur by hematogenous lymphatic direct spread or transcelomic spread. And some of the metastases which are commonly seen is colorectal, breast, and even common tumors like RMS, Wilms tumor, neuroblastomas, Ewing's, and rhabdoid tumor of kidney have known to have secondary tumor potential in the ovary.
What is the absolute indication of